Hi, welcome back. We're going to have the privilege of watching Dr. Julio Rodriguez, a colleague of mine, a vascular surgeon for many years, do a venous case on a patient who has, we think, an iliac compression. Now, I say we think because he was just like we were talking about, ultrasound findings of a high velocity, but not terribly high, and symptomatic in his both legs. So both legs are bothering him, but his left leg is slightly larger than the right. So we're kind of putting all this together. Dr. Rodriguez has seen the patient, and I think he's going to introduce the case when he comes on live. Are we ready? Hi, Julio.
Hi, good morning, everyone. We're glad to be on a program this morning. We are transmitted live from Arizona Heart Hospital. We are here with the great team of this institution, and we're going to have a couple of interesting cases for you today. One is going to be transmitted in the afternoon. And we have also a nice case that we recorded a few weeks ago of phlegmasia. We have a time we can present that one as well. But let me just give you a little brief introduction and history on this case. This patient is 74, is rather obese, and he has a long-standing history of swelling of the legs. But he pointed out that the left side is worse. Now, he denies any past history of DVT or any problem with veins or any intervention, except that early this year in January, he underwent atrial fibrillation ablation. And since then, he referred that symptoms got worse. Also has important to know a prostate cancer that has been treated with radiation recently, and some other minor troubles on him. But the main problem is that he has pain on ambulation, mostly on the left side. So if we move ahead with the history, we did a quick ultrasound on the arteries just to make sure that we're not missing anything in the arterial side. It just pointed out, and the next slide you will see the result of the arterial duplex, very normal values. In the right, perhaps 50% on the common, but nothing in the left that you can think this is an arterial issue. Now, the next one will show you the venous duplex. It's gonna have a bunch of numbers there, but the patient overall has some deep reflux, deep system reflux. Greater saphenous vein is actually very compressible and normal. We don't see any reflux in that. But right at the iliacs, it pointed out perhaps some compression and some velocity that signified something important for him. Now, I met this gentleman yesterday. In most of this kind of scenario, which I suspect some may turn, I'll probably move ahead and do a CAT scan. Unfortunately, we did not have that available. I just put him on a schedule. Maybe it might be an interesting case to show and see what we find in this gentleman. So I have the patient in supine position. I make an access in the left common femoral vein. I look at that with the ultrasound yesterday. It looks good, and it looks actually very clean. I didn't see any clot at all in the area. So I put a sheet there, and I will show you the venogram on this patient. So shooting from the 9th range, can we get, yeah, let me have some contrast. If you see there, maybe you can loop this image here, Ben, so they can see the flow through the vein. We have a pretty normal external iliac vein, but as the flow goes up, you can see that there is some sort of angulation right at the distal common iliac, and another angulation at the top, what might be the transition between iliac and cava. I did a RAO view just to see, and those are still persistent there. I don't know, you have that image over there, Ben, that you can run as well. We did like a 45-degree. The hypogastric become in our way and that angulation, but it may enhance even more the area of the iliocava. But what she's interested in is that there's a density change between the external and the common iliac. How that impressed you, Dr. Thorpe?
Yeah, I think that you have a little bit darker flow, some stasis there in the external iliac below that. I've been pointing out that that angulation is pretty severe.
Yeah, I think that's the right word. Yeah, you see a dramatic change in density, so it makes you feel that maybe some sort of obstruction. Now, I have a 035 volcano IVUS catheter. We're going to use that. We're going to run this for you. I'm going to put it all the way up into the vena cava. Can we go live right here?
This is an 8 French volcano over an 035 wire.
Yeah, it is. Many times I use the Eagle Eye catheter with the 014, but I think in this gentleman we'll see better with this one. He is kind of a big guy. So what we're looking now is kind of a mid-infrarenal vena cava. It's pretty normal, nothing really to... I'm wondering, do you have the images there?
Yes, we can see them. I can see the renal coming off.
Yeah, okay. So I start pulling back slowly. It's a pull back here at the vena cava. We're going to slow down right at the transition between the cava and the iliac, which is probably coming right next here, just to see if there's anything important here. So it just flatten up. I'm just sit the probe right there in this area. The question here, if this is significant on this patient to justify symptoms. So I'm going to continue coming down. This is the common iliac vein. If we can quick do measurements, maybe AP 12 to 6 to see how big is this vein. So we have close to 12 millimeter, and then let me just move down the probe so we can get a better sample of the...
Now that's in the common iliac?
We are at the end of the common. See, yeah, right there. Now, let's do... Yeah, I will show you, yeah, because it's interesting what I found here. Now, let's do just a transverse quick measurement here. I just want to have those numbers so when it comes to time maybe to do some ballooning here. So we have a 17. All right, now, let me show you this. I'm going down to the distal common iliac, getting into the external, and this is what this patient has. It's a very tight stenosis right there, and then suddenly open up again in the external iliac right there. It's almost jump from above this stenosis to this point. So that agree with the density change in dye. It just kind of stop there, and then it just gets more clearing on the top on the common iliac. Now, so the two things here is the changes at the common iliac at the vena cava area, and this one at the end of the common iliac vein. What your thought about that is those are, I'm convinced that we have to dilate this one, this stenosis. I'm not very sure about there's something that we have to do at the common iliac vein, at the area where the artery normally compresses the vein.
But you don't want to put an isolated external iliac stent, do you?
Yeah, that's my question. That's actually what I think is just coming up from the common iliac down to the external.
Mahmoud, what do you think?
Well,
It's Dr. Rasavi, Julio.
Yeah, Mahmoud Rasavi here.
All right, nice.
Couple of observations. Number one, I agree that that area of looks like either lower common iliac or upper external iliac, I'm not sure which, is compressed, and that probably needs to be treated. The other observation on a venogram is that you had a bit of retrograde flow in the internal iliac vein, which always, to us at least, we look at collaterals to help us to see if a lesion is hemodynamically significant or not. The issue of how long to stent, we can argue that until tomorrow. My personal preference is just to minimize the length of a stent and limit it to the area that is narrow. Have However, in this case, your common iliac vein looks okay up at the top to me, at least from your IVUS. That would be my vote, at least.
Yeah, I think I share that opinion. Yeah, I think we can probably dilate this area of the distal iliac, transition to the external, put the stent in that area and see how it looks. We always can't overlap anything else above that, but I'm not very impressed with the cava iliac area. With it's kind of, we can actually look at it again with the IVUS here.
That particular location also, I mean, Patty will talk to us later about different patterns of venous compression in the pelvis, but that is not an uncommon area for a compression of the artery also. So it may not be, the etiology may be compression rather than something related to radiation or something.
That's pretty narrow to me. Did you do an
It is.
AP
Yeah.
diameter?
Yeah, we can do that. Can you measure that one? Just the minimum diameter there, Ben.
If that's the confluence area, that area should be stented too.
Yeah. Here we go, 6.2.
And what's
All right.
the transverse?
Do the transverse measurement too. Then we did it just behind the probe. Here we go. It's 19.
So it's about 30%. I mean, it's 60% stenosis, AP.
Yeah. Do you normally pre-dilate this, Dr. Thorpe?
I do. I think that's tight enough to stent, and I have a preference for extending the stent into the IVC. I think the longevity is greater. I know this gentleman's 74, but particularly a younger person. Yeah. I've seen too many isolated iliac stents thrombose.
Yeah. Any other preference on how to stent this common iliac here? Be specific above the stenosis, or this is which one?
Well, why don't we take a review here of the panel? Dr. Sharifi, what would you do?
I agree with you, Dr. Thorpe. I think you have two significant stenosis. One is at the confluence level, and the other one is your classic May-Thurner. So the stent should be extended from the distal part of the IVC, covering the confluence, and into the other side.
Yeah, all right. We're going to start dilating the area of the external iliac right here. Go ahead. I choose a 12 millimeter balloon just because the external iliac, yeah, you can see some waste at the beginning of the inflation.
What size balloon is that?
It's a 12 millimeter. Yeah, the sternal iliac was actually 10 millimeter. It's a little bigger on the above.
I would be interested to see what the balloon looks like when you do the common iliac right near the cava. That right angle is kind of an odd shape.
16. All right, let's take it down. I'm going to use a bigger balloon for that area. I think I'm going to start with a 16. Is the maximum size that I can put through this 9 French. Is the balloon deflated, Ben? Okay. There we go. So selection of a stent, could we make maybe a discussion from the panel? I think most of the people prefer a wall stent for this kind of work. If there's any other position here.
Well, we have Dr. Razavi here.
Yeah, I personally, I mean, the problem is that because of the size of the vein, you're somewhat limited on what you can use. Nitinol stents are not available unless you're on a trial. For these larger ones. I have a preference towards nitinol stents, but in this case, you may not have much of a choice.
Yeah. Yeah, I use a lot actually the nitinol stent before. Up to 16 is perhaps the biggest that you can get.
14.
Yeah, go ahead, Andy. 14, yeah. I think EV3 has, I'm not sure EV3 has a 16, but
You know, the other issue is how do we size stents in these pancaked veins? There's going to be a controversy. I mean, that's controversial already. And how do you size your stent in a situation such as this? We go by diameter because that's the only thing in the vein that's, I'm sorry, not diameter, but perimeter. That's the only thing in a vein that's constant as you increase, as you change its dimensions. And then back calculate what the diameter should be if it was a
do it
circle.
again.
What, Mahmoud, do you look at the normal appearing vein in the external iliac and try to kind of match it to that?
Yeah, external iliac may be, you know, in these situations, if you size it by external iliac, you may be a little undersized. And so there may not be, unless there's a good common iliac, then you size it to that. The other situation is if you were really in a May-Thurner situation, then you could look at we have been looking at the perimeter of the vein based on IVUS and back calculate, and it comes very close to what you think is normal.
Yeah. It's basically like a volume measurements rather than a diameter. All right, let's take it down.
You can also always put a catheter on the other side, the contralateral side, and look at the quote control vessel and measure that if you're really in doubt.
Yeah. Let me just do an angio here on this view. We are pretty much AP. Janice, could you help me maybe do a little Valsalva to hold a second then to see if we have some reflux on the other side and get a better bifurcation?
Okay, let me know. You ready now?
Ready, yeah. All right. All right, let's run this one. You definitely can see some sort of compression at the top of the, okay, but from this one you can see that. Now, can I have the IVUS again? Let's just quick do a repeat IVUS to see if there's any changes here.
So as you guys do that, Patty, in this case, you said you would extend your stent into the IVC.
Julio, are you thinking you might extend the stent up into the IVC?
Yeah, I'll tell you what I do as a practice. If you go live, I can show you with the IVUS where I would consider putting the stent here. Can you enhance the angiogram so we can see the roadmap better? Yeah, I would say yes. In this case, I probably have to go somewhere above this area here. Let me have just a needle and so we can use that as a marker. Now the question, should we do a transition from the cava all the way down to the external iliac?
Well,
Let's see what it looks like.
Yeah.
ideally you want to start your stents high and maybe use one stent to cover both lesions if possible. You don't like to put one stent below and then have to troubleshoot another lesion above. So he has to make that decision now about where to start the upper stent.
Yeah. All right, this is the area with the common iliac get flat, right there. That probe is. I'm right now 2 centimeters above this area with that needle. Can you all see the needle marker that I placed right there? And that's is going to be 2 centimeters above this zone, which is actually in the vena cava. Is that acceptable for you, or you normally go higher than that?
No, that I would see where it flares at that point because you have this odd angle. Your stiff wire will straighten it out a little bit. But I would definitely go at least that high. Anybody
That
other
high,
comment,
yeah.
Dr. Daugherty?
I agree.
I think that's
Yeah.
fine. I probably would put a 24 by 70 wall stent in this, starting a centimeter or two above the confluence of the iliac veins.
Yeah, let's look at the other area that we just dilate here. It's gonna be this one. Look at that. It looks actually better. It's gonna break that fibrosis there, or whatever is compressing right there, the vein. So, so we have a 74 wall stent here. Diameter, probably we have to go all the way up to, what's the maximum size that we have? We have the 20 here? 24, 74? All right. Any other consideration in regards to selection of a stent? I'm thinking maybe 24, 74 to bring it all the way down to the external iliac. If I measure or use the IVUS to get that measurements up to that needle, it's going to be, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 centimeters from the IVUS, and this 70 millimeter. All right. Not sure if that will reach, but we're just looking here at the stock of wall stent that we have. Yeah, let me have the 75. Here we go.
You have to upgrade your sheath size?
I think it goes that one through 9, isn't it?
Need an 11 sheet.
Let me see. Yeah, you're right. That one, it takes 11. Let me have an 11 sheet, please, or 12 French sheet.
Julio, you have plenty of time. They're running a little late in the other room, so don't hurry.
All right.
So
All right, good.
As you're changing that, let's have a little discussion of what size of stent would you use if you had nitinol stents. I think a 20 millimeter stent would be oversized if you had nitinol stents because they behave differently, obviously, than a Wallace stent does. Wallace stent would probably be okay, oversizing to that degree. Looks like you're sizing to the longitudinal, the largest diameter of that pancake vein. Is that correct?
That's correct, yeah.
Yeah.
Yeah, I think, well, starting on the vena cava down to, I mean, I feel that it may shrink a little bit on the common iliac. Hopefully we'll reach the lesion at least 2-3 centimeters below that.
Yeah, you see, for Wallace stent, that would be okay because when it's compressed, it looks like a diaphragm. It compresses in all angles circumferentially rather than nitinol stents, which behave differently.
Yeah, it's right.
Yeah, the nitinol stent would be, obviously, even 20 would be oversized for this location. But Wallace stent, I think you need to do that.
Oh, definitely. No question, yeah. Yeah, the nitinol will try to reach its nominal size, so it don't accommodate probably as good as the wall stent.
I've seen these things done elsewhere where people put in very small stents, and I think that's one of the problems with stenosis on many of these. Certainly with a wall stent would advocate going large. We typically will size at 4 to 6 millimeters nominal diameter, larger than the largest portion of the vein we plan to stent. And that's resulted in virtually no significant restenosis in these non-thrombotic lesions.
Patty, how would you size that?
Well, I'm surprised that he's going that large because I usually go to the size of the vessel down below. Okay. Because I probably was going to, I was thinking an 18. I was thinking an 18 or a 20, but I'm...
All right, well, I can stick with the 20, actually. Let's open the 20, same length. Yeah. Just thinking at the top area once we open in the vena cava, but yeah, that's fine. 20, I think, is acceptable here.
I think you'll get good apposition for most of the stent.
Yeah. Ben, can you run the angiogram so we can see a little more of the vena cava? Here we go, right? You just stop the image when it feels right there. Yeah, that's good. And see if my needle is still in the right place over there.
Julio, could you take a mosquito and point out where the needle is? It's hard for us to see
Sure.
it, actually. Thank you.
Yeah. Let me have a mosquito, please. It's right here what I'm planning on coming. That will be the top of a stand. What do you think?
I think so. It'll retract a little, as it flares.
Yeah, sure. All right, let's open the 20 or 55. We don't have a longer one, no?
We have an 80.
Yeah, the 20 millimeter stand, what happened is the one that we have is 55 and there's an 80. I think 80 might be too long for this.
Well, 80 might extend to your external iliac lesion nicely.
Yeah. All right, open the 80. Yeah, we can use the 80.
These stents never open up to their nominal diameter except in the inferior vena cava. Once they get into the iliacs, they're usually not as big as they're advertised. Do you agree, Mahmoud?
Yeah, I agree, and it may turn out, because your external iliac is smaller than 20, it may turn out to be longer than 8 centimeter.
Yeah. Yeah, we often see that, so it's difficult sometimes to determine the length. I just want to cover both lesions with a single stent. We'll not stack a couple of them in there.
I want to point out to people here that there's a curve. This is straight, and then it goes posterior and curves forward right at this point where the hypogastric comes in. And so you want to be able to stent past that curve, or you get a very strange angle into the back wall of the vein. So coming down a little bit lower and covering that lesion that's right about there is probably going to be perfect for you.
All right, so this is now the 20 by 80. So in that technique, we just bring it all the way up past that marker. So a little bit of resistance there. You see that?
Mm-hmm.
Yeah. So I'm going to
What
bring it up
what
to
wire
this
are you
point.
using?
It's an 035. I can actually exchange it for a stiff one because even when I passed the probe, it got stuck right in that area. So I'm sure that that's actually the culprit of the whole problem that this gentleman has. All right, so starting out this high, I have like a couple of centimeters or half centimeter and a half above the needle. I'm gonna probably accommodate that, somehow bring it back a little more. But even if we deploy it up there, I don't think it's gonna be a big problem for us. Will you agree with that position to begin with?
I think it looks good, and I think the distal aspect is going to be perfect above the inguinal ligament.
Yeah, I agree. Yeah,
All right. All right, so I'm gonna start opening the stent, looking for that big flare up in the iliac.
Can they magnify the view?
Yeah, they're asking for magnification here, Ben. Can you do that? We know that we are passing both lesions very safe, so it's okay if we get off of the road map for a moment. All right, how is that view for you?
That's better, thank you.
That's better, okay. I'm gonna bring back just a bit the stent. Gonna open a little more. As many of you knows in the audience, that second mark before the finish of a stent is a mark that you can still retrieve in or close the stent if you want. Once you pass that mark, you're pretty much committed with the deployment. Here we go. How's that looking?
Looks good. It looks pretty tight
Yeah.
there in the external.
Yeah, it does. So I'm gonna stock a little bit, pushing forward the rod, so
You may,
Here we go. Oh, you can see now the funnel shape of that stenosis. Can you?
Yes, right here.
Yeah. All right. Let me have the balloon again. Yeah. Huh. It's interesting because I didn't know that was actually that tight. We're going to touch that with the 12 millimeter balloon again. I might get even, we can even dilate it more if we think we have to. I think at the top, the stent opens nicely.
It's very tight there.
Yeah, it is.
Do you know if that was in the field of radiation for his prostate cancer or not?
Yeah, yes, it was. And actually, I think it might be an important factor for this one. I'm seeing arteritis very often come up from radiation, but I'm sure that maybe the vein get affected as well, right there, yeah.
And you're using a 14 millimeter balloon?
Yes, this one is a 12.
12, okay.
Yeah, the external iliac was only 10 when we measured it with the IVUS. Here we go. Yeah, keep going.
Still a waste.
It is, yeah.
Is he experiencing
No,
any
the
pain or is he under anesthesia?
No, we put them on there, yeah, because I mean
Yeah.
the waiting and all that, but yeah, I bet it will hurt. I mean, looking at the IVUS after we did an angioplasty in this area, definitely there's some scar tissue inside that vein, you know. Is this is coming up from the radiation of some sort of previous thrombophlebitis in that region? The interesting thing is that the remaining vein looks pretty normal.
Yeah, and for anyone in the audience who doubts whether or not you should stent, if you angioplasty that type of lesion, you won't get any result. It won't help very much. So you have to place a stent here to take care of this stenosis. I'm surprised it won't open all the way.
Yeah. Go live for again, Ben. Let's see it. Let's see how many atmospheres we have. Yeah, let's get a little more pressure here. All right, let's see if this thing collapse again or will stay open here. Definitely looks better now. I'm going to dilate it some more over here. Yeah, I think we're getting the results that we want here.
Yeah, I'd like to see with IVUS. The balloons often break at the ends of the wall stents, don't they? This is a good balloon so far.
Yeah. I try not to come down very much because of that, yeah. All right, let me have the bigger balloon now.
Before you put the bigger balloon in, do you want to do a venogram?
Yeah, I can do that. Contrast. What do you want to make an assessment of the lower part first?
Yeah, I'm a little concerned if you go beyond 14 that it may be a little too much. Oh, I see.
What Dr. Razavi is saying, you don't want to foreshorten your stent so that you go above the lesion, right?
Yeah, I think we have plenty of stent past that, isn't it?
Looks good.
Yeah. We'll see the IVUS, what it shows. Let me just dilate the common iliac now. Go ahead.
There is a slight stenosis there, isn't there, in the common?
Yeah, it is. Go higher across the center right there, yeah. I don't see any waste on this one. Now, as always happens with this wall saying, you dilate one end, the other one gets smaller. Let me
Yes.
just touch one more time this area here. There we go. All right, let's get him ready for the IVUS now.
Any questions for
Just take
Dr.
this.
Rodriguez from the audience here?
Yeah, let me just finish here with another venogram, and then, meanwhile, you start getting the IVUS in. Get this one as a roadmap so we can do the IVUS over this image here. Yeah. Definitely by venogram, it looks much better, faster flow.
No, notice that there's no change in density of the contrast in the iliac. Now
very
it's all
yeah,
one color.
Very solid. That's right. All right, go ahead. Could you go live while we're doing this, Ben? So we appreciate what's the area that we're going to. All right, it's starting again up above the stent in the cave. I'm going to do a pullback here. Let's watch the stent. You keep bringing down this tissue that we see in the probe, so we have a clear image, Ben. Here we go. That's the stent sticking into a vena cava distally. And this is actually the common, yeah. It looks pretty well rectified right there. Coming down into the area of the previous narrowing. This is actually
The tight spot.
our diameter. Yeah, the tight spot. Can you measure that one over there so we know how big it was? All right, we're close to 12 millimeter diameter. And coming down to the other end of a stent, live on the IVUS, here we go. Coming down to the other end. Let's just jump all the way back. We just want to check the transition of the stent. Well position right here, Patty, you see?
The transition is good. It matches the vessel.
Yeah.
But there is a one, could you go back up a little bit? There's one area
will.
that just for discuss, right about there.
Yeah, you just passed it.
Yeah.
How important do you think
Yeah.
it is to, there's pros and cons here. If you really super expand your stent just to fill in that gap, you're going to foreshorten your stent. What do you think, Mahmoud?
Now,
I think it may not
measure
have
the
a choice
stent only, stent.
because it is restricted by that lesion below it. And so this is what I was talking about, the wall stent sort of constricting in a like a diaphragm like this. It does not conform to the vessel wall above it, above a stenosis if your stenosis is not completely dilated. So there may not be a choice in here. I would probably dilate that a little bit more.
But I want to leave.
All
I
right.
want to say that I don't think it's bad to leave it that way either, because it's not detrimental to the vein
Oh, it's not.
or
no,
the stent. There's plenty of flow through that stent. It'll stay open.
Yeah, not at all. What was the measurement of the IVUS you just took on that stent?
Yeah, it was 14 centimeters. So
Yeah.
this is a 20 stent. It's restricted here to 14. I think it will expand some more. I can touch that with the bigger balloon, no question about that. It just, as we see the behavior of this stent, as you very well highlight that, is that something you dilate here and it gets smaller on the other end. So you have to kind of keep dilating until you're satisfied with that. But I think it's going to be all right. It will expand some more at that area.
I think the more we look at it, the more it looks like radiation, because all
Yeah.
that white area right there looks like radiation fibrosis. So that's why there's this mismatch between where it's really tight and the part above. But I think he's going to have a good clinical result.
Yeah, I think it was a good thing that we find this because definitely I finished with this case having more findings on the venogram right there and the IVUS than it clinically and duplex showed me. So it's good that we treat them and we got this result. Well, I don't know if there's any comments or questions we can ask for you.
Any questions? Anybody? No, they're all just enthralled with the result.
Okay, can you just comment about what is your post-treatment anticoagulation or antiplatelet therapy regimen, and when are you going to remove that sheath? Right now?
Yeah. Yeah, I'm gonna pull the sheath and hold some pressure. I think that we do some compression dressing as well. I think the gentleman, yeah, that's a good one. He never had a DVT before. I don't have any reason to put him on a accompanying. I think I'm gonna start this gentleman in Plavix. The other things that we can use for him is Xarelto nowadays. I have kind of mixed feeling with that, based on some experience, but I would love to hear what you guys think about this.
Well, Dr. Sharifi has his guidelines, I'm sure. Dr. Sharifi, what would you do?
Well, definitely the sheath can come out right now with some pressure. If there has not been a DVT, there is no need for anticoagulation with warfarin or any of the new oral anticoagulants, and I just leave them on aspirin.
All right.
How about you? Anybody else on the panel, Dr. Daughtery?
We do lifelong aspirin. We do 30 days of Plavix on these.
Mm-hmm.
Yeah, because of
Great.
if there are no contraindications, obviously we don't know. But this is a non-thrombotic case here. It would be okay if you didn't anticoagulate at all, but antiplatelets are something we would definitely put them on antiplatelets.
Good.
Do you have him fully heparinized?
I did heparinize him, yeah.
So do you reverse the heparin yourself, or you just wait for it to wear off, or what?
I wait to wear off, yeah.
Okay, so they'll probably
don't do it
pull
as
the
a
sheath
routine.
in a little bit.
Yeah, I will.
Well,
Well, I appreciate the comment. Yeah.
Yeah, just one comment. You really don't have to reverse this, and you don't need to wait. Even people who have received thrombolytic therapy in the venous circulation, you can just pull out and put some pressure, and that would stop in a few minutes.
Completely agree with that, yeah. I don't think we have much trouble with that neither. Well, thank you very much.
Well, I want to thank everybody there that we didn't meet besides Dr. Rodriguez, because it's a good team and the OR3 there today, and all the audiovisual people there. Thank you very much. I think we all really enjoyed this case. It was really great. Thank you.
Thanks very much, Patty, and thanks to the panel.
Okay, we'll see you this afternoon.
See you at 1.
Okay, well, I think that was great. It's our first live case for CVC on the venous side, and so I'm very happy that it was very worthwhile teaching, don't you think? Okay, Dr. Daughtery. Move the stool.
No
Okay.
stool. Where's our pointer?
There you go. Okay, now we get to talk about pelvic congestion syndrome.
Well, I want to open your eyes to a different cause of pelvic congestion syndrome than what most of you have learned. We learned 20 years ago that reflux in the ovarian vein caused pelvic congestion syndrome in some patients. And indeed, there are many gynecologists who now believe that there's no venous cause for pelvic pain because they've seen so many people treated for their ovarian vein reflux who didn't get better or got worse. I think we now know the answer as to why some of that's been happening. Chronic pelvic pain lasts longer than 6 months. It's commonly attributed to endometriosis, hormonal changes in the vaginal epithelium, ovarian cysts. But about 30% of chronic pelvic pain is said by more than one study actually to represent a venous cause. Pelvic congestion syndrome involves pelvic pain, tenderness, usually dyspareunia, postcoital pain, dysmenorrhea, vulvar congestion, and their back pains, pelvic neuralgias, and sometimes urinary tract symptoms. The common pathway is pelvic venous hypertension with venous dilatation, local inflammatory changes, and I'm sure it's much more complex, but if you look at this, some of it's reflux. The ovarian vein is the typical one, usually the left ovarian. The internal iliac vein is sometimes blamed, and it's probably true sometimes. Obstruction may cause it too. Left renal vein compression by the superior mesenteric artery and the aorta will cause flow to pass down the ovarian vein into the pelvis, causing pelvic congestion symptoms. Occasionally, a lesion in the inferior vena cava will do it, and more commonly, a left common iliac vein lesion. Clinical history is important. You don't find these if you don't talk to patients and ask questions. Most are C0 through 3. They have variable pain and edema. They have pelvic pain, dyspareunia, postcoital pain, sometimes lasting a week or more in some of these patients. Chronic low back pain, sometimes bladder symptoms. They often have had non-diagnostic studies of many kinds that really haven't answered the question. And on pelvic exam, they'll be tender. Just an abdominal exam, they'll be tender across the lower abdomen, usually the left lower quadrant, sometimes the right. They may complain of pain and discomfort in the groin on either side and may be tender there without necessarily obvious clinical changes with varicose veins there. Some will have lower extremity edema. Some will have dependent cyanosis in the leg. Many do not. Some will have labial perineal varices, infragluteal varices. This patient sitting on the exam table didn't look asymmetrical at all, but in fact, standing, there's a little bit of a venous cyanosis in the left leg in this patient, but her primary complaint wasn't her pelvis. She was just miserable with pelvic pain, dyspareunia. These are suprapubic varices on the left and infragluteal varices on the right that you see on some of these patients. We work them up. If they have significant GI or GU issues, we work that up. But we do an abdominal venous color duplex study. We usually work up their legs too, because most of them have some degree of venous insufficiency. And we use the CT or MR venography really just to help define anatomy a little bit better before we treat. And occasion in the patient where we have a high index of suspicion that there's a pelvic venous lesion and we're just not finding it with ultrasound. And finally, we diagnose with intravascular ultrasound venography. The transabdominal study is to look at anatomy. We want to look at flow direction and velocity. We look at peak venous velocities and peak venous velocity ratios. We talked about earlier. We look for collaterals, retrograde flow. And then finally, we look for intravascular lesions versus compression. You can see on this, this is the common iliac vein, vertebral body here, IVC. This is artery compressing the vein here. This is common iliac vein with peak venous velocity of 60 centimeters per second, which is very abnormal, and a very tight vein here. This is almost continuous flow as well. And here, we've exercised a patient. And we get continuous flow in the common iliac vein after exercise. That's the lesion there. And this is the internal iliac vein, which shows retrograde flow. So we know there's pelvic collateral that's physiologically significant in that. On the left, you can see some varices in the labia. We don't really do that study to specifically look at those, but if by ultrasound, you can see these in the labia. This is a 9 millimeter diameter varix in the labia right there. And some of these patients are very symptomatic from it. You saw this earlier. This is just the drawing our text do to show us the anatomy and retrograde flow here, which is 100% specific for this significant lesion, but it's not as sensitive as we'd like it to be. And finally, here is an MR which shows right and left common iliac arteries compressing the iliac vein, stretched across the vertebral body. The geometry here is interesting. It's usually stretched across in this arc of a circle, and then it's compressed against the bone there. And finally, there's some varices there to see. This is an injection showing one of these kinds of problems. This is an injection in the renal vein, right there. There's very little flow out in the cava. The flow is down the ovarian vein into the pelvis. And you can see these cross-pelvic collaterals that are huge. This patient has been miserable most of her adult life. This is treated most commonly with a left renal vein transposition. This is actually a fairly rare lesion, but it's very real. You can do other things with the anatomy. You can do a venous bypass and other less commonly done things, but the transposition is the most common approach. And on this you can see a drawing showing how the vein is compressed by the SMA in the aorta right there, and it's treated by just moving the vein down here. Mayo Clinic has had some of these, and they wind up in a significant subset stenting them later if a stricture develops right there. You can stent these primarily, but I don't encourage that except in a research setting. We're just not ready for stent technology for that in most settings. Occasionally there's an IVC obstruction, which causes a variety of symptoms in the pelvis or the abdomen, sometimes pelvic congestion syndrome, and you can treat that usually with a stent. You may see collaterals on the chest wall or abdominal wall, and you may find leg symptoms as well. Iliac vein obstruction is usually non-thrombotic. It's usually compression of the left common iliac vein, maybe a Weber stricture occasionally. Bleiler reported in 1999 treating post-thrombotic iliac stenoses with stents for pelvic symptoms with great results, but hardly anybody remembered it. Dave Gillespie and I reported 2 years ago, and this came out this month in Journal of Vascular Surgery, 19 lesions that were compression in 18 and one inferior vena cava stricture treated with stents for pelvic congestion syndrome. You've seen this image before. This is the kind of thing that you see with decreased contrast density in the left to right collaterals. Intravascular ultrasound shows compression of the vein here. This is the stented vein, the same location. And this is a venogram of that patient with a stent from here to here with the cross pelvic collaterals being gone. These are numbers we reported a few months ago with these patients, stented in the left common iliac vein. There are 26 of these we had for follow-up as long as 7 years. Median pain score went from 8 to 1, 8 to 1 for pelvic pain dyspareunia, 8 to 0 for postcoital pain. Back pain improved too from 8 to 2, some leg improvement. So these are very real. Ovarian vein reflux is real, but I would submit that many of these cases where the ovarian vein is large, it's actually an outflow vein, and that outflow vein, when it's seen as being large, is thought by some to be the problem, when in fact it's an outflow pathway that makes the patient better. But still, there are some lesions that are real with ovarian vein reflux, and those are most commonly treated by ablating them. We use 3% sodium tetradecyl sulfate and iodinated contrast for injections into the pelvic varices and then platinum coils in the ovarian vein. Some use occlusion devices of other kinds. The internal iliac vein reflux is treated by some. I almost never do this because I almost never find anybody where I think this is the problem. And I just don't see patients who remain symptomatic when I don't deal with internal iliac vein reflux. So I'm not saying it's not useful, but not for me very often. This is a video which shows a patient done elsewhere. You can see coils in the ovarian vein and coils in the internal iliac vein. Let's just see if we can get this thing to replay so they can see the flow. And they missed some obvious clues that this was really an iliac vein compression, but they saw a large ovarian vein, they had tunnel vision. They decided, boy, we better go coil that big ovarian vein causing this patient's miserable pelvic symptoms. So they didn't look at the left iliac at all. They went up the right femoral, put a catheter in, up down in the renal, down the ovarian, put coils in, then they went down to internal iliac on the left, put coils in there, and the patient was not any better. Several years later, after years of just being miserable, she showed up after moving to our state, and we ultrasounded her. We saw the lesion, and this is an injection in the left femoral. You can see real clues. First, you see these left-to-right collaterals that pass across here. Second, let's try to run this again so they can see this up here. There's decreased contrast density up here, and then there's this huge ascending lumbar vein. When you see that ascending lumbar vein like that, you know there's a lesion up here above it that's restricting flow. So these collaterals are the patient's problem. All this was obvious and easy to diagnose, actually from some of the imaging that was done elsewhere, but they had their blinders on, and so they missed the real lesion. And I'm seeing more and more of this out there, people who've had these ovarian vein coils, and the real problem was not the ovarian vein. This is this patient with a stent placed. The cross pelvic collaterals are gone. The ascending lumbar vein is much smaller already, and this is moments later after placing a stent. Thank y'all.
I have a question for you. How often do you stent the, how often do you stent the iliac when there is evidence of an ovarian vein that's refluxing or some varices, and the patient actually gets better? You don't have to go in and coil the varices.
Well, about a third of the patients that we find with severe iliac vein compression that's causing the pelvic congestion syndrome also have ovarian vein reflux. And we just don't treat that anymore, and they all get immensely better. We occasionally have one that has just a little tiny bit of residual discomfort, but it's been several years since I've actually done an ovarian vein occlusion in a patient who had an iliac vein lesion. So we're selectively treating the obstruction first and seeing how they do. Now someday I'll have somebody where I need to go back and coil an ovarian vein, but I haven't yet. In our practice, when we find these patients with pelvic congestion symptoms of vascular cause, 10% of them are ovarian vein reflux, and 90% of them are iliac vein compression, a third of whom have some reflux. And I really think it's primarily an outflow pathway in most of those patients. But we're just not seeing significant residual symptoms in these patients.
Thank you.
Thank you.
Well, thank you. I'm going to talk about various patterns and findings in May-Thurner, and you'll see a case that looks very similar to the one we just saw, actually. So I do have one disclosure to make, that I do consult with Volcano because we did over 10 years of IVUS before, but I started that though. And the tiger tourniquet is something that you'll see a little bit later on today when we talk about pedal vein, tibial vein thrombosis. Well, syndrome is an interesting word because a lot of people say the patient has May-Thurner syndrome, and then people will tell me, well, it's mostly in women, isn't it? And the syndrome itself derives from this word, that's Greek word meaning concurrence. So we know it's a set of medical signs and symptoms that get this label, but sometimes, as in the case of the May-Thurner syndrome, is it the iliac compression or is it actually the syndrome? And is the syndrome the leg swelling, the discoloration, the groin ache, the claudication when you walk, all because of the compression, or is it actually the compression itself? My feeling is that pretty much the clinical syndrome includes all of those symptoms that go along with the finding that you have a tight anterior-posterior diameter in your iliac vein. A lot more men are showing up with, quote, May-Thurner syndrome now because they've added a risk factor of testosterone injections. And the syndrome presents when you have sort of a perfect storm of risk factors. Factor 5, birth control pills, May-Thurner compression, a broken ankle, a twisted ankle. So multiple risk factors add up to a deep vein thrombosis being caused by the iliac compression. But the syndrome itself, when it's non-thrombotic, is that constellation of swelling and ache in your groin, and your left leg being a little bit bigger, or your left shoe always being tighter, things like that. So it can be asymptomatic, and you can have a compression. It can be symptomatic with no DVT. It can be symptomatic with an acute DVT, or you can have the chronic pattern that's well compensated, and then you only find out about it when you get the second DVT. See, and I'm pointing that arrow there because to make me remind you to tell you that we need to look above the inguinal ligament with our ultrasounds, or we won't find these lesions many times. Now, iliac compression is not a male-female issue. This syndrome may have more manifestation in women because of pregnancy, postmenopausal hormones, other things that give risk factors to developing the DVT. But 50% of men and 50% of women have an iliac compression because a third of the population has an iliac compression if you read the autopsy reports that have come out over the years and do the analysis of that. So in the United States, if there are about 300 million people, there are about 100 million people that have an iliac compression. Not all of them are symptomatic, but all of them are potentially a problem if they add additional risk factors, like radiation therapy for that man we just saw, flying from here to Australia. All kinds of different risk factors come into play to develop the syndrome or the DVT that goes along with it. It's very underdiagnosed, it's very underimaged. This is a case that we just had last week. The patient had, I was talking to you about the fact that we had no DVT. She came in with swelling, no DVT, just a little bit of chronic thrombus in her right leg. All of the acute thrombosis was up here associated with the right and left. She had an iliac occlusion that it turned out that was from 2009. It's a long time ago that she had this known problem. So she was going to be sent home, except for the tech decided to look higher. The right leg was swollen quite a bit, and she turned out to have a pretty normal-looking left leg. So I said, if you have an IVC obstruction and you have a pretty normal left leg, you must have a huge ovarian vein compensating for that, and so she did. But this is a picture of a patient who has never thrombosed. You have an iliac vein compression and a left leg swelling that's visually obvious, and it bothered her, but she'd never had a DVT. Compare that to the next patient who had a DVT. The ankle is equally asymmetric, but she has the post-thrombotic syndrome. They look very similar, don't they? So it's all in the history. This is a lady who had a 70-year-old woman who had an AFib procedure with this big left front sheath and a big hematoma in her left groin, a massive DVT. And this is a patient who's only 28 years old, taking birth control pills, factor V Leiden that they never knew about, ends up with a DVT on the left side because of an iliac compression. So it's one of the pieces of the puzzle is the iliac compression. It's generally not the whole story. This is a person who has a malignancy, which we know makes you very prone to thrombosis, and then on top of that, she has an iliac compression. And here's a 21-year-old with a chronic DVT. Her legs don't look too bad, but it's definitely a little bit bigger on the left, but she's symptomatic. And I've often seen that the amount of swelling doesn't correlate with the amount of discomfort. People can have a lot of pain and hardly any swelling. People can have a lot of swelling, and it really doesn't hurt them. So you have to look at each individual. This is a young man that Dr. Rizami knows because he was a young man that had this very large left leg, and it turns out that he had a combination of a left iliac compression, but once we stented him, his leg didn't really get a lot better because he actually has a lymphedema on that side. And so I've seen that scenario 3 or 4 times now, particularly in young people, where they've got precox, lymphedema precox, and not enough lymphatics. So here are a few pictures, some patterns of May Thurner. We're just going to run through these pictures. You can see the different manifestations of the same problem in different people. Some people get a lot of these different channels here, too many to count, very fine. I usually put my wire up through the medial or lateral one. Usually you don't want to go this way. Here's another one where you see the iliac artery crossing over, and there's some high bifurcation of the hypogastric and a big collateral over to the right side, very chronic occlusion. And there is the IVUS to show you how narrow it is. Here's a post-thrombotic May Thurner. shunting from right to left. The body always does this here, and sometimes at 3 levels. And here's the ultrasound for that particular patient, always very tight, front to back, very wide, side to side. And here's the stent placement, showing that it goes nice result for that patient. Now, non-healing left ulcer on the left side is often a clue that you have an iliac compression. And this is a C6 patient, and there's before the stent, and she was stented here, and then afterwards, let's see what happened here. See there, 315, there's a stent, and that's how tight that lesion was. And there's a stent placement, a stent in place, and there's the stent on the CT, 3D CT, and here's the, within just a couple of weeks, a lot better, still not gone away, but it's resolving. Ultimately, she resolved that lesion, and it came back. So we knew the stent was open, so at that point, we had to treat a perforator. And this is what I call Mega May Thurner, a very tall, large woman, 6'2", and she had high velocities in her left common iliac with almost a flat line below that and the distal left common iliac. And she had a very large vein here. On MRI and on venography, it defied everyone. And I said, well, has anyone ever looked with IVUS? And what we saw, you can see it's almost 3 centimeters wide here with the ascending lumbar here. But with IVUS, you can see that it's very tight front to back, a lot of scarring here. So even though we don't have stents that are 3 centimeters wide, we don't need to have, because we can just put a very large stent, maybe a 22 here. It will be very tight from front to back because of all that fibrotic tissue. And you can see the iliac artery compressing it and how wide it is. And there is the vein stented. The stent stays in place, it's anchored down here, it's anchored from front to back, it's never going anywhere. There's the pre, here's the post, and this young woman made a miraculous 24-hour improvement. It was amazing how fast she recovered from all of her symptoms, which actually had her limping. It hurt so much. So here's what I call a right angle or 90-degree May Thurner, which is kind of what we just saw in that gentleman. Actually, you have a very high internal iliac takeoff here. And the stent goes up here, the wire goes up here, and the stent comes way up to here. So that was that resolution. There's the IVUS, kind of hard to see there. And how narrow it was, front to back. And there's the stent placement. Here's a bilateral May Thurner. We're finding that more and more with the bifurcation of the aorta here. The arteries, if they're tortuous arteries or just the angle of insonation here with the angle of bifurcation, you can actually take out both iliac veins at a slightly different level. So bilateral May Thurner is not that uncommon. And here you can see the 2 channels here. There's usually a septum there between the vessels. See clearly the 2 channels here. Now here's what I call a double May Thurner. You have actually 2 equal vessels on one side, probably a septum of fibrosis. But here it's confusing because when you look with IVUS, you see 2 equal sized vessels. You say, wow, should we stent both of them or what? See, hear that? I usually just stent one channel here, and this channel will stay partially open. It won't thrombose, but you want to have one really good channel that is inline flow to the heart, so it reduces the amount of drag, and both of these are compressed. So you want to create one really good channel. And I've learned not to oversize it. I usually size it to this vessel right here. So you want it to match this vessel here and go up high to the cava. And here we are with just the result there and the result here. There's the stent in place. And there's one case I have of recurrent thrombosis, or recurrent what I call May Thurner. This is pretty rare because I stented this young woman in 1997, and she came out to Phoenix 2 years ago. and she was having more symptoms finally, and when we looked, it turned out that her stent had retracted. She had had about 2 babies. She'd had 2 babies since then, and I believe, I've never seen, but her stent actually was down below the lesion you could see with IVUS, so we extended the stent up and it resolved her problem. And another thing that we see fairly frequently is what I call half Maytherner. It's just the impression of the vessel on this side, and when you look with IVUS, part of the vessel seems to look really, this should play here. Oops, I don't know if you can make that play. But the outside, 1/2 of the vessel on IVUS is definitely very narrowed, and the other half looks fairly normal. And what I've done is I've learned to stent these people because they definitely improve. You can see how narrow it is. And then one part seems to be good, and see it opens up quite a bit with just a narrowing on 1/2 of the vein. And this particular patient, we didn't stent at first, and she went on to have another thrombosis in her popliteal tibial. So at that point, we brought her back, and I stented her, and actually she felt much better. I mean, we did it to prevent more DVT, but I think that I'm sure everyone here on the panel could agree with me that we're constantly learning. Every patient is a gift, and we learn from every single one of them. So thank you. That's my talk. Now I'd like to, it's a pleasure to introduce Mahmoud Razavi from Orange County. He's an interventional radiologist that has been a colleague of mine for many years, and he's going to talk about splanchnic venous thrombosis, visceral thrombosis, and challenges and opportunities. Thank you.
Thank you. Let's see, where's your... Okay, these are my disclosures. And so splenic vein, most of the time when we're talking about splenic vein thrombosis, you're really talking about splenic vein and portal vein, because the mesenteric veins, isolated mesenteric venous thrombosis by themselves are not very common. So most of the time it involves the portal vein and the splenic vein, and those are the patients that present often in the clinics. Now, the true incidence is not known because frequently these are picked up on imaging studies, and sometimes the patients are asymptomatic. Most are asymptomatic, and I mentioned they are just incidentally found, a lot of them on patients who have liver disease. Estimated lifetime risk in general population is about 1%. That's based on basically all those incidental findings also. However, in the setting of acute splanchnic vein thrombosis, that includes obviously mesenteric venous thrombosis, there is a high incidence of mortality and bowel infarction. The third-day mortality is about 20%, and that increases to about 60% or so over 5 years. Now, a lot of these 5-year ones are due to other causes, such as liver disease, for example. Nevertheless, it has a high mortality when you see them. Genetic causes of venous thrombosis, definite causes are on the left side, and the probable causes are on the right side, as you can see. And this one here is just a huge number of causes of acquired etiologies for venous thrombosis, as everybody's aware of. When you boil this down to few for those that cause or predispose patients to splanchnic vein thrombosis or mesenteric venous thrombosis are these. And most presumed idiopathic splanchnic vein venous thromboses have an underlying thrombophilia, especially myelodysplastic syndromes. And so it's recommended that when you have these patients and you don't find any cause, look for JAK2 mutation, which is an acquired entity. Now, findings on imaging, you can see thrombosis of various venous structures. So that is easily picked up nowadays on sophisticated imaging, MRs and CTs. You can see ascites, pleural effusion, bowel wall thickening, cavernous transformation of portal vein. Here's a patient that you can see both pleural effusions and ascites, and you can see there is a cavernous transformation of the portal vein, also all of them in one patient. Here's a different patient. As you can see, there's mesenteric edema and this thickening of the bowel. These are the patients that are usually acute. These are the patients that are usually at risk, and they need treatment right away. Now, the management is based on natural history, which is not well understood. Spontaneous resolution is uncommon, except if there are patients in acute pancreatitis, because the pancreatitis resolves, and so does the thrombosis. Indication for treatment is really based on low-level evidence, and that includes anticoagulation and interventional catheter-based treatments. Surgical treatments are usually because there's bowel infarction or severe ischemia. Those are different. But when you're talking about interventional management or anticoagulation, the level of evidence in the literature is very low, unfortunately. And that has to do with the fact that they're not very common. Now, observation addressing the underlying cause has to be done, obviously, in every patient. And anticoagulation duration is based on the etiology of disease. Sometimes the etiology is resolved like pancreatitis, and obviously you don't need to keep them on long-term anticoagulation. However, if they are predisposed or they have a thrombolytic condition, then they need to be on long-term anticoagulation. The catheter-based intervention includes mechanical or pharmacologic declotting of the, basically removal of the clot, plus minus a stenting. TIPS is an integral part of most of these patients, and that's transjugular intrahepatic portosystemic shunt, for those who are not familiar with it. And I'll explain that in a second when we get into the results, because one of the common reasons for rethrombosis is actually the velocity of flow in the portal vein. And when that velocity is low, rethrombosis is high, and thereby that's why TIPS is done. And TIPS is usually a common pathway to treating these anyway. Now, surgical thrombectomy and resection of necrotic bowel, that needs to happen when there is necrotic bowel. Now, current recommendations for the management of these patients, the splanchnic vein thromboses, conservative or anticoagulations for non-progressive thromboses with a small clot burden. So if they're found in patients that are partially symptomatic or they're symptomatic and it's non-progressive, a small clot, those are anticoagulated only. Catheter-based treatments for acute, progressive, or extensive thrombosis or failure of anticoagulation. This is one of those areas that unfortunately not all interventionalists are familiar with. So when the local expertise exists, it should be tried. Otherwise, they're not that easy. They're easier said than done. And most of it has to do with the access into these veins. Surgical, obviously, if you have evidence of severe bowel ischemia or bowel infarction. Now, recanalization with anticoagulation alone, what does the result look like? Overall, all the patients, about 30 to 40% recanalization. 70% if the treatment is instituted in the first week. So if the patients are caught early and the cause is determined to be the thrombosis of the mesenteric veins or the portal vein, and they're anticoagulated early, there's actually a pretty good recanalization rate. And 25%, it drops to 25% when you go into the second week. And that's where catheter-based treatments are important. Low success rate in extensive thrombosis, it just doesn't happen, just like a regular DVT. If you have extensive iliofemoral DVT, they're not going to get recanalized with anticoagulation alone. And splenic vein thrombosis and ascites are independent risks for failure of anticoagulation. So in our practice, when patients present with those, and they typically go to gastroenterologists, they don't go to the vascular specialist. Thankfully, our gastroenterologists are in tune with these entities, and they call us immediately. Those are the patients that usually are intervened upon, depending on the symptoms. Catheter-based treatments, the transarterial thrombolysis via SMA infusion used to be recommended or practiced, but it's really efficacious or would work in patients who have thrombosis of the small mesenteric tributaries. They're not effective in cases of extensive thrombosis in the obviously portal vein, the splenic vein, or the mesenterics. Direct declotting procedures, what we call through transparenchymal approaches, either through the transhepatic or transsplenic or via TIPS, are the way to go. Now, I have done 3 patients with direct ileocholic venous approaches where the other approaches did not work. We couldn't get access across the occluded superior mesenteric vein. So what we did is we had our surgeons with a great deal of arm twisting give us an incision in the right lower quadrant to a loop of bowel. Then we found the vein and recanalized these patients in an antegrade fashion. I tell you, if your surgeons are not familiar with these, there's no way you're going to get them to do that. They just won't. Our surgeons were transplant surgeons. They're used to big things, and they went ahead and did it. But it actually works very nicely. When you go in an antegrade fashion in these veins, recanalizing them is very easy. Now, thrombolysis with plasmamechanical thrombectomy is typical once you're in these veins. Here's give you a couple of examples. Here's a patient, as you can see, mesenteric edema all over the place. You can see thrombosis of the portal vein right here. I can't get this thing to work. And here's the reconstructed images in the same patient. This image shows that this patient had a mesocaval shunt surgically placed before. So obviously, the patient had portal hypertension. And now that whole thing has thrombosed. This is the venogram in a lateral projection through that mesocaval shunt. As you can see, the mesenteric vein is thrombosed above that level of occlusion. And this is post-declotting and reestablishing flow into the portal vein in the numbers, as you can see over there. Now, this was done by a different operator. If this was one of our patients, this would be followed by a TIPS. And the reason I mentioned to you is because when you look at the velocities of blood flow in the portal circulation after declotting, if those velocities are low, that's a very high rate of recurrence. And so we TIPS these patients to improve the velocities, and the rate of recurrence is actually very low once you TIPS them. Here's another patient, interesting one, 51-year-old female, presented with abdominal pain, nausea, vomiting 2 months prior to this admission. No specific diagnosis was made, and the patient was the repeat admissions 2 weeks later for the same problem. Now, this is why a lot of these patients go undiagnosed, is because they have a little bit of abdominal pain, they get treated, they go away, they come, it goes away by itself. CT reading was tumor at the time they did a CT, and they did a biopsy that was negative. And so the worsening of the condition, they did an exploratory laparotomy, and they found that there was infracted bowel. They resected part of that, and diagnosis of mesenteric venous thrombosis was made 5 weeks after the initial complaint. And attempted recanalizations failed, so they sent the patient to us. And here's what the CT looks like, and this is why they biopsied this. As you can see, liver looks very heterogeneous, which is not uncommon in these patients, by the way. Here's our approach. As you can see, we did the transparenchymal through the liver access, and you can see the chronic occlusions, contracted veins. So this has been going on for a while. This is not acute. And so we went ahead and recanalized, and the only open vein that was normal was the inferior mesenteric vein, as you can see on the right side of the image, and the superior mesenteric vein is that middle structure which looks chronically occluded. Nevertheless, we went ahead and tried for both of those. Superior mesenteric vein failed, so we decided to connect the inferior mesenteric vein to a TIPS. And here's through the TIPS, which we could not do, but then we used our wire as a target for the TIPS, and here it is. Through the transjugular access, hit that vein and accessed it, and here's our access through the TIPS. And then the whole thing was stented afterwards after a trial of thrombolysis, and here finally established flow antegrade. And this patient did better. This was 10 years ago. This patient still comes for follow-up, doing fantastic. A couple of restenosis within the TIPS that were treated by angioplasty afterwards. Now, results of catheter-based therapies, efficacy, here you can see complete flow restriction is about 50 to 60% and partial about 20 to 30%. So about 80% of these patients with the transparenchymal or TIPS approach, you can reestablish flow. Survival is actually very good, about 89 and 81% at 1 and 2 years, and safety about at 6% bleeding complication rate, and that's when you go transparenchymal. That's where they could bleed in the spleen and in the liver. This is where the experience comes in. And risk reduction with meticulous technique, ultrasound-guided venous access, targeting the intraparenchymal veins, and use of low-profile systems, so on and so forth. In conclusion, acute splanchnic vein thrombosis is associated with a high mortality. This is an acute setting, and a speedy diagnosis and therapy is critical. And in a chronic setting, these patients can be treated with catheter-based therapies also if they are symptomatic. If they're not, obviously you don't. Thank you very much.
Okay, now I'd like to welcome to the podium for the last talk of the morning session is Dr. Nieves from Bogota, Colombia. He's a vascular surgeon visiting us here for this meeting, and welcome, Ernesto. He's going to speak about venous ulcers.
Okay, thank you very much for the invitation. The English not is my natural language. Please take patient with some mistakes. Okay, this research is about a big problem, not just in South America. It's very common in the United States. About the 1% of all population have the leg ulcers. And we have to think in the reflux when we talk about the leg ulcers. This job was about to compare two treatments. The first one was the very conservative treatment with no compression, just healing the leg ulcers, and closing the venous hypertension vein using the foam in this treatment. The group was very similar, and we did follow the 3, 8, 12 weeks, and 6 months. This is the characteristics of the groups, and we had 24 ulcers in the both group, the control group 24, and the endoluminal occlusion found 24 again. Was very similar in the ulcer area. The age was the other thing. Patient within very young and very older, 22 years, 82 years. The technique was using Tesari technique for doing the foam. We use in this part of the study the lapidium is a very popular substance for sclerosing the veins in some countries in South America. And the other part was we didn't use the compression in either of the groups. We have the results at 3 weeks, 8 weeks, 12 weeks, and 6 months with no compression, just basic healing the leg ulcers. Is a resume of the natural story of the leg ulcers with no compression. We don't have this information previously. And when we closed the venous hypertension with foam, we had 83% of the healing in the leg ulcers. I found that it was very, very secure procedure and minimal invasive technique, and very superior to this control group. But in other words, we did nothing. This is the SCAR study, maybe the best study in the world about the treatment of the leg ulcers, when they compare compression alone, multi-layer bandage, and compression with surgery. At 6 months, they had 65% of the closure of the ulcers. At the end of the first years, almost 80%. It's expensive, need a group of nurses to do these treatments. And with this information is a great level about the compression, is a level of evidence A, grade 1, and the evidence for doing a surgery, a normal surgery, is just 2, and level evidence C. Okay, we had these results. We found if we close the superficial hypertension in the leg ulcer, we have 83%. And this is the best treatment in the moment, and doing the multi-layer system to doing the compression. After that, these results, we try to do the closing the venous hypertension and plus the compression with multi-layer systems. And we call this protocol TAPIRS, closing the terminal, axial, and perforator interruption of the reflux, closing the axial insufficiency in the superficial veins, perforator, and the terminal reflux. And the result was very interesting. We had in this protocol 17 patients between 47 years and 85 years, very older patients, all with active leg ulcers. And in this case, we use polidocanol at 3%, close all the veins in the axial axis, the perforators, and the terminal veins. At the end of the 6 weeks, very faster, we could close the 100% of the leg ulcers with this technique. And we were very impressive with the results because we didn't expect this faster healing. If we took all the leg ulcers area, we had maybe 230 centimeters in leg ulcers, and you can see how was the reduction in the time, all closed before the 6 weeks, and 100% of these patients could close the leg ulcers. This one case, 88 years, this old woman with a big ulcer and a long time of evolution. This is the first week with the cleaning. And we did the closing of the venous hypertension in the same day. We didn't hope for cleaning the leg ulcer for doing this treatment because it's minimal invasive. This is the way that we did. This, the 4 week, is almost closer, and at 6 weeks, we close all the leg ulcer. These are control at 6 months. There are other cases, but the result was very similar. Week 0 and week 5, and again, in 3 weeks, we can close the leg ulcer.
Are you talking?
The same, 3 weeks and 5 weeks. I can close all the leg ulcers with this technique. Okay, is other cases because we're a little patient, but there are some photographies when we start the treatment. At the end of the 6 week or 4 week, we can close all the leg ulcers. In resume, this was our first result, 83% using the foam for closing the venous insufficiency. And when we use the foam plus the multi-layer system, we have a very faster result to close these leg ulcers. We need other studies to confirm our results, but these dates suggest that more aggressive approach to this connection between the venous hypertension and venous ulcer could give a better treatment, faster treatment. If the results are faster, it's less expensive. This is an American TAPIRS in our country. Thank you very much.
Yeah. Okay. I think we have time for only one question if somebody wants to ask a question. Otherwise, it's time for a break. I don't see anybody. You're probably hungry and ready for lunch. So thank you very much for staying in the session, all the questions this morning. We'll welcome you back this afternoon, and please don't forget to see the vendors. And we also have another live case from Phoenix this afternoon. So thank you.